Without any further ado, let's start with our first session on hands-on workshop. This session entails laparoscopic ergonomics and needle handling. This session will be conducted by Professor Sajida Qureshi. She is a distinguished general surgeon specialized in upper GI bariatric, laparoscopic and robotic surgery. Her advanced laparoscopic workshops are famous, and today we have the privilege to have her as the chief facilitator. Let's welcome her with a big round of applause, Professor Sajida Qureshi.
Assalamu alaikum and good morning, everyone. Thank you very much for your kind words. It's an honor to be here in company of my two great teachers sitting here, Professor Mumtaz Meher and Professor Amjad Siraj Memon. So without much delay, I think we'll start with our workshop for today. So before we start, so what I would like to do is, you know who I am, and I'm here to try to, help you go through a few things that you find difficulty in whenever we are talking about laparoscopic surgery. But before that, I would like you people to introduce yourselves, and we would like to know what are your expectations from this workshop, and what is your experience, what have you been doing so far. So if we can have the mic to the first candidate. Who are the candidates? Can you please raise your hands? Okay, good. So we have got quite a few. So we'll start with you, Dr. Saab, here. So please introduce yourself, where you're working, and what is your experience of laparoscopy, and what are your expectations from this workshop today?
बिस्मिल्लाहिर्रहमानिर्रहीम। मेरा नाम डॉक्टर मोहम्मद यासीन है। मैं जनरल सर्जन हूँ और मैं पाकिस्तान पेट्रोलियम लिमिटेड का हॉस्पिटल है सुई में, सुई फील्ड हॉस्पिटल, उसमें काम कर रहा हूँ और 2015 से मैं लेप्रोस्कोपी कर रहा हूँ। मैंने वहाँ शुरू भी की थी और प्रोसीजर्स जितने भी हैं मैंने यहाँ JPMC में और मुमताज़ साहब से भी काफ़ी मैंने लर्निंग की। मैं अभी वहाँ पर लैप कोली, लैप अपेंडिसेक्टोमी, हर्निया में TAP और TEP दोनों और लेप्रोस्कोपिक टोटल हिस्टेक्टोमी, ये तमाम चीज़ें वहाँ कर रहा हूँ रेगुलर बेसिस पर और अल्हम्दुलिल्लाह रिजल्ट्स बहुत बेहतर हैं। और यहाँ मैं कराची में जो भी कहीं लेप्रोस्कोपी की वो कॉन्फ्रेंस या कोई इस तरह की ट्रेनिंग होती है तो मैं कोशिश करता हूँ अटेंड करने की। आल्दो मेरी थोड़ी सी एडमिनिस्ट्रेटिव असाइनमेंट्स अब कंपनी में काफ़ी बढ़ गई हैं, लेकिन ये आपकी जो ट्रेनिंग है इसको जब देखा मैंने तो मुझे बहुत इंटरेस्ट डेवलप हुई, क्योंकि स्पेशली इंट्राकॉर्पोरियल सूचरिंग में जो है वो मैं शायद उस तरह उतना वेल वर्स अभी तक नहीं हूँ। हालांकि मैं प्रैक्टिस घर में भी करता रहता हूँ, तो मेरी एक्सपेक्टेशन यही है कि इंशाल्लाह मैं जिस तरह से इतने सीनियर टीचर्स अल्हम्दुलिल्लाह इस वर्कशॉप में मौजूद हैं तो यकीनन बहुत ज़्यादा इंशाल्लाह लर्निंग होगी।
So you're mainly interested in suturing, learning. Otherwise, you are well acquainted with the equipment and how to. Okay, fine. Dr. Kanaya.
I am Dr. Kanaya Lal. I am working as a general surgeon in Sindh government in district Gotki for last 18 years, and I have started laparoscopy in 2014, and I came here in OT complex in 2014 under supervision of Professor Sajida Qureshi to refresh me, because for a long time I couldn't use laparoscopy instruments. Now I am doing laparoscopic cholecystectomy, appendicectomy, diagnostic laparoscopy, and simple procedures like liver abscess, drainage, and lymph node biopsy. But I use extracorporeal knots, but intracorporeal suturing I am deficient in this procedure. So my expectation is to learn mainly intracorporeal suturing.
So not tying and suturing,
Yeah.
right?
Yeah.
Okay.
Assalamu alaikum. My name is Dr. Farhan Ali, currently working as Senior Registrar General Surgery, Gambut Institute of Medical Sciences, Gambut. I postgraduate from Mayo Hospital, Lahore. I did a couple of workshops on basic surgical skills, laparoscopic surgical skills from different workshops. here I want to do the advanced laparoscopic surgical skills so that I can implement at my center and do further in this field.
So have you ever tried knotting and suturing intracorporeal?
Yes, ma'am. In couple of workshops I did,
Okay.
but later on I forgot because I was in
All right. Okay, fine, fine.
मैडम मेरा नाम डॉक्टर गुलनसीब खान है। मैं बडग्राम हज़ारा डिवीज़न से आया हूँ केपी से और कोई बिगिनर हूँ मैं लेप्रोस्कोपिक सर्जरी में। मैंने कोई 7-8 इंडिपेंडेंट कोलिसिस्टिक लैब कोलिस की हैं, लेकिन इंट्रा कार्पोरियल और एक्स्ट्रा कार्पोरियल सूचिंग बिल्कुल इससे पहले एक वर्कशॉप अटेंड की थी, लेकिन वो उसमें मुझे हार्डली 5 या 10 मिनट्स मिले थे सूचरिंग के। तो इससे लर्न करना चाह रहा हूँ इंट्रा कार्पोरियल एक्स्ट्रा कार्पोरियल दोनों सूचरिंग। और लेप अपेंडिसेक्टोमी अभी तक मैंने नहीं की, सिर्फ कोलिसिस्टेक्टोमी, वो भी 7-8।
Okay.
Assalamu alaikum everyone. I'm Dr. Tayyib Siddiqui, currently working in Patel Hospital as junior faculty. I'm sorry for the voice. I have attended the similar workshop previously, and it really helped me in giving me confidence that I can do it on the patient. So just want to have more confidence after the end of the day.
So when did you last attend this workshop there?
Few months back that we had this
Okay. All right. So you thought that you had learned something from that workshop, or you did not? That is the reason you are back. You want to have more confidence. Okay, fine.
Assalamu alaikum. My name is Dr. Fatma Yusuf. I am a resident at Surgical Unit 2 Civil Hospital, Karachi, and I want to learn the basic principles, basic instrument handling, and also added advantage would be to learn intracorporeal and extracorporeal knotting.
Which year are you in?
R4.
R4. Okay.
Assalamu alaikum. My name is Dr. Hafiza Bushra. I'm general surgery resident in Surgical Unit 2 Civil Hospital, Karachi, and I want to learn basic principles and instrument handling in laparoscopic surgery.
So have you done any lab colis prior?
Ma'am, almost 3 to 4.
3 to
not more
4.
than
Okay,
that.
fine.
I'm Dr. Kamal Sikandar, general surgery resident in Civil Hospital, Karachi. Since I'm under my training, so I am expecting to have a good experience over here. I just want to improve my basic skills, and I have done 2 to 3 lab colis recently, so I am expecting that I'm having a really good experience since we are having a lot of mentors here. So
Okay.
Assalamu alaikum. My name is Dr. Kamal Nissa. I'm a general surgery resident starting my year 4 of residency in Patel Hospital. Since I'm a trainee surgeon, so I'm interested in the entire outline and want to improve my basic skills for the laparoscopic surgery. So interested in all the principles and suturing as well.
All right. Okay.
Assalamu alaikum. I am Dr. Alim, currently working as general surgeon in Walika Hospital, and I want to enhance my laparoscopic skills regarding suturing and knotting. And currently I am doing lab appendicectomies and lap colis.
Okay.
Assalamu alaikum. My name is Dr. Harim Fatma Hussain. I'm currently working at Hashmani's hospital. I came to a similar workshop that was held by you last year, and it gave me enough confidence to be able to perform laparoscopic cholecystectomies. So I'm here for a refresher course and also to add to that repertoire.
Yeah.
Assalamu alaikum. I'm Dr. Zakia Madat Ali, surgical resident at 3 at Surgical Unit 2. I'm here to have a better understanding of basic principles of laparoscopic surgery and knotting suturing.
Okay.
Assalamu alaikum. My name is Dr. Marine Ansari, and I'm a third-year resident at Surgical Unit 1 Civil Hospital, Karachi. I feel these workshops are a great place for us to get oriented and utilize the simulators for practicing our advanced laparoscopic skills and get a basic idea. So hence I'm here. Thank you.
All right. Who's left? Anyone left? Can we have the mic on that side, please?
Assalamu alaikum. I am Dr. Jahara Hassan, working as a consultant general surgeon at District Ghodki. I am doing laparoscopic cholecystectomy, and here I am here to learn intracorporeal and extracorporeal knotting and suture.
Assalamu alaikum. I am Dr. Sabha Nazir, working as a resident general surgery in Surgical Unit 5. I'm here to learn basics of laparoscopic surgery, basic ergonomics, with an added exposure to intracorporeal suturing.
Assalamu alaikum. My name is Dr. Sumla Salman and I am a resident in Surgical Unit 6. I've had some exposure in laparoscopic cholecystectomies. I am here to fulfill my deficiencies, whatever there are in basic principles, and move on to some advanced skills.
Assalamu alaikum. My name is Dr. Hassan Shahab, resident Surgical Unit 6, Year 4. Just attending my first laparoscopic workshop and excited to learn new things from it.
Assalamu alaikum. My name is Dr. Komal. I am resident Surgical Unit 5, Civil Hospital, Karachi. I want to learn the basic principles of the laparoscopic surgeries.
So have you done laparoscopy before?
Yes.
Assisted? Okay.
Laparoscopic cholecystectomies 4 to 5 and laparoscopic appendectomy.
Next.
Assalamu alaikum. I'm Dr. Bushra Javed, Air 4 resident in Surgical Unit 5, Civil Hospital, Karachi. I want to learn the basic laparoscopic skills and move. I have done laparoscopic cholecystectomies 3 to 4 and just hone on my skills more and move forward.
Next, please.
Assalamu alaikum. My name is Dr. Sobia Rafi. I'm working as a consultant general surgeon in a couple of private hospitals in Karachi. I've been doing regularly laparoscopic cholecystectomy, appendectomies, and ovarian cystectomies, and doing intercorporeal knotting as well. But I want to get more exposure in intercorporeal suturing. So I will be focusing on that. Thank you.
I'm Dr. Rajpat, Year 4 resident at Surgical Unit 4, Civil Hospital, Karachi. I am doing laparoscopic procedures like cholecystectomy, appendectomy, and few more. But I have assisted a lot of procedures. My main learning purpose in this is whole workshop, including basics and further intercorporeal knotting.
Assalamu alaikum. I am Dr. Yusra, working as a resident Year 3 in Surgical Unit 4, Civil Hospital, Karachi. And talking about this workshop, I am keen to learn the basics of laparoscopic surgery, from instrument handling to different types of suturing.
Assalamu alaikum. My name is Dr. Aneza. I am a 4th year resident in Surgical Unit 6, Civil Hospital, Karachi. I attended your workshop last year as well. That gave me a lot of insight into the basic principles. Today, my keen interest is learning intracorporeal knotting.
Okay, so that's it? Yeah. Okay, so we have a mix of candidates here. There are people who have been doing quite advanced procedures, and there are beginners as well. So please, let's make it a very interactive sort of a workshop. It's not going to be a lecture. So what we would need is input from you. If you people do not understand anything, please feel free to stop us there and then, and we can discuss, we can demonstrate. So it's going to be pretty informal. All right? So since majority of you know what laparoscopy is, and the best way, because it's the way forward. Nowadays, you cannot go into your practical life without learning minimally invasive skills. And these minimally invasive skills include both your laparoscopic as well as the robotic surgery. And the best way to learn and the safe way to learn is to learn on simulators. And these sort of workshops, they give you an opportunity to avail this opportunity that you have been given to learn in front of your mentors under supervision, because supervision is a must. All right, so I'm sure all of you must know what laparoscopy is, why is it done, when it is done. So if somebody asks you what are the indications for doing laparoscopic surgery, what would be your answer? Or rather, if I ask you, since all of you have been doing laparoscopy, what are the prerequisites for starting laparoscopic surgery? Can I just stand up today and say, oh, I'm going to do laparoscopic surgery because it's a very new in thing nowadays to do? So, anyone? What are the prerequisites? This, I think, each one of us should know. Come on, anyone? Sorry?
Proper training of laparoscopic.
Excellent. So I think that what is most important in this technique is you should be trained to do laparoscopic surgery. Okay, it should not be that thing that you have seen one, assisted one, and you start doing the procedure. Remember, laparoscopic surgery is very complex surgery. It has a very steep learning curve. And each of the surgery, each of the different procedure has got a different learning curve. And you have to achieve that curve before you go on and start doing laparoscopic surgery. So if I'm very good at doing laparoscopic cholecystectomy, that does not mean that I would tomorrow stand up and start doing laparoscopic colectomy or gastrectomy for that matter. All right? So what is most important is to achieve your learning curve, and for that you need experience, you need learning, you need teaching for it. All right? What is the second thing that you need for doing laparoscopic surgery?
Training of the whole team, the other staff members.
So you need to have a trained team. Can we give chance to others to speak as well? There should not be one person. I told you this has to be interactive. We'll not go far if you people just sit quietly, okay? So yes, you should have proper equipment, you should have a proper theater layout, and you should have a trained team. Like Dr. Amjad said at the beginning, you should know how to hold the camera. If your camera person is not trained, your skill as a good laparoscopic surgeon would not do much good to you, actually. Because if the camera person is not showing you where you want to see on time, that's going to make the process tedious and not very efficient. Okay, so what are the contraindications? When would you not do laparoscopic surgery? Nowadays, laparoscopic surgery can be utilized for any surgery that you are trained for. You have proper equipment, you have proper theater accessories and equipment with you. Okay, so what are the contraindications? When would you not do laparoscopic surgery? These are all the things that I usually teach when I'm doing a basic laparoscopic workshop, and I expect all of you to know that. What are the contraindications for doing laparoscopic surgery? When would you not do it? No, that's not a contraindication. Nowadays, majority of the emergency surgeries are taken up laparoscopically as well. What is the contraindication?
Cardiopulmonary.
Okay, so first of all, there's training. Okay, we have sorry? Yeah, that's what we have emphasized. The training is must. Apart from that, clotting disorders, these are all relative contraindications for open as well as laparoscopic surgery. We are talking specifically about laparoscopic surgery here. What would be, which would be those situations where the patient will not be tolerating pneumoperitoneum? So people who are severe cardiopulmonary compromise, then it depends on what the status is and how does your anesthesiologist feel about it. If you want to do a small diagnostic procedure and your anesthesiologist is happy to give anesthesia for a shorter duration, you can perform that procedure. Okay, so how do you learn? Laparoscopic surgery, we have all established it has got a steep learning curve. Why do I say it's got a steep learning curve? Huh? Anyone? How is it different from open surgery? Why do you think it takes a longer time for you to learn laparoscopic surgery as compared to open surgery? Hand-eye coordination. So you're looking at the monitor, you're operating at a site which is distant from where you want to operate. Your target organ is far away. So you're operating from the abdominal wall or the skin, and your target organ is far away. You're looking at the monitor, you're not directly looking at the site where you're operating. So you have to have. So the best way we have established is to work in a safe simulated environment like what has been provided for you today. So what problems do you have when you're doing laparoscopic surgery? Why do you think it's difficult? Apart from this hand-eye coordination, anything else that would make it a more challenging procedure? Very good. So what do you understand by depth perception? That you cannot perceive the depth adequately when you're doing laparoscopic surgery? Yes? Why do you think it's so? And how can you overcome it?
Because it usually provides two divisions.
Okay, so one is that when you're doing open surgery, you have got 3D vision. When you're doing laparoscopic surgery, you just have two-dimensional vision, okay? So one is that, one is the hand-eye coordination. Third is inability to perceive the depth. What else? Loss of tactile feedback. What do you understand by this term? What is tactile feedback?
We cannot touch the tissue by our hand.
So how does it help? I understand that tactile feedback is when you touch, it's soft, it's firm, it's hard. How does it implicate you doing the surgery?
You can't feel hard and soft tissues, and this will help. If we do it laparoscopically, maybe we can injure some organ.
Because you do not know how much traction, how much force you have to apply for that part. How firmly you have to hold, how softly you have to hold. So all this makes it a procedure that would need a lot of experience and lot of a steep learning curve. So these are all the challenges that you face in laparoscopy. You have got two-dimensional vision, you have got lack of tactile sensation, lack of depth perception. You have to be bidextrous. In open surgery, you can get away working with your right hand only if you're a right-handed person. But in laparoscopy, remember, you have to be bidextrous. Otherwise, you're not going to be a good laparoscopic surgeon. You should know how to hold the instrument, how to hold the needle with both the hands. Sometimes you have to go and apply a stitch from your left hand. You cannot, if you're holding a critical tissue in your right hand, naturally you're not going to leave that and then grasp it with your left hand and then use your right hand to take a knot or suture through it. So you should be bidextrous. Okay, so hand-eye coordination. And the other important thing that makes it more challenging is fixed range of movement. See, your human wrist has got a 360-degree movement. I can move my wrist all around. Whenever we're doing laparoscopy, you're working with stiff, long instruments. And how much degree of freedom do they allow you? Only 4. What are the movements that these laparoscopic instruments allow you? Up, down, in, out, right, left, clockwise, anti-clockwise torque, isn't it? So you have to overcome this. And how do you overcome this? Is by experience. Keep on training, keep on training, keep on practicing. Okay, so laparoscopic geometric principles. So the 3 main obstacles that affect your initial learning curve is your visualization, okay, lack of depth perception, and fixed range of laparoscopic ports. Okay, so how do you overcome each one of those? What do you mean by visualization? I thought in laparoscopy you get a magnified view, isn't it? So why is visualization a problem in laparoscopy? Anyone? Think about it, because you people have been doing it, and this you all agreed was something which was quite challenging in laparoscopic surgery.
If camera skills are not appropriate, then we cannot visualize the things properly. And if pneumoperitoneum is not appropriate, then
we're just talking about, let's limit ourselves to visualization thing. So it's good, isn't it? If you see a magnified view, that's good. So why is visualization a problem? So there's loss of peripheral vision. So there's a panoramic view and there's a magnified view. So how does it help? So since you have a 2D vision, there's lack of depth perception, so you would not be able to know how much far it is. So what is it affected by visualization? Visual distance and visual angle. What do you exactly mean by that? When I'm saying this might seem quite difficult for you to understand, but what is visual distance? If I bring in my camera, how far is this camera from my target organ? This is your visual distance, right? And what is the visual angle? The angle that your camera is making with your target anatomy, that's your visual angle. How does it affect the surgery? Does it affect the surgery? Why? Because if the target organ is at an angle, it's up, it's down, it's in a crevice, in a cavity, naturally if you go closer, then it's going to make it more easier for you to appreciate it. Yes? So what is visualization? 2 main factors affect visualization, your visual angle and visual distance. So remember, these are inversely proportional to one another. So as the visual distance decreases, it increases your visual depth, and it gives you a good depth perception. This is commonly known when you're doing surgery or when you're assisting a surgeon, you would hear him tell you time and again, come closer, come closer, come closer, bring the camera closer, right? So this is what it achieves. So if your camera is quite far from your target organ, you'll not be able to perceive the depth adequately. For you to perceive the depth adequately, you'd need to bring the camera closer to the target organ, okay? And visual distance, as it increases, it decreases the visual angle, but gives a good panoramic view, but depth perception is lost. Sometimes if you need a panoramic view, you're going to bring the camera back. And when you are bringing the camera back, as the distance increases, your visual angle is inversely affected, and it would give you a panoramic view. Got it? Samajh mein aa gaya sabko? So the two things that can affect or improve your visualization is by manipulating the visual distance and visual angle. Okay? So this is the panoramic view. So what do you mean by panoramic view? What is the visual distance here? Far. And visual angle? No, visual angle is more, or is it less? It's less? It's more. And what is that view? Magnifying view. So 45 degrees visual angle is optimal. So now they have done several studies, and they found that if your visual angle is 45, that gives you optimal depth perception in 2 or more direction between 2 or more structures. Got it? So the other principle that would help you is the triangulation. Okay? So what do you mean by triangulation is? What is triangulation? Okay, so triangulation is the relationship between your instruments, your right hand, left hand, between the assistant instrument and the camera as well. So remember, for you to do an efficient laparoscopic surgery, you need to follow this principle of triangulation. So these instruments at all the time should form apex of the triangle at the target anatomy where you're operating. Okay? And the other thing is that it has got, triangulation has got 3 components, okay? So one is the angle between the instruments. So that's the angle between the instrument and the plane between the instruments and the visual angle, okay? So what are the ideal angles? So you must have, in your exam as well, there's commonly on the OSCE station, they ask you about the azimuth angle and the manipulation angle and the, so this has come, these numbers have come after a lot of research and after a lot of feedback from different surgeons who have been doing laparoscopic surgery. So they have found that the ideal angles for you to do a very efficient laparoscopic procedure is that this manipulation angle and the elevation angle should be 60 degrees. It can be any range from 45 to 75, but the best optimal is 60 degrees. But that doesn't mean that you cannot work at 70 degrees. That also helps, depends on the situations. So what is the manipulation angle? It is the angle between your right hand and your left hand instruments, okay? And what is the azimuth angle? Is the angle between your ports, your right hand or left hand instrument and the camera, okay? So that's for optimal, it should be 30 degree. Elevation angle, what is elevation angle, guys? Yes, excellent. So it's the angle between the abdominal wall and your instrument. So this has to be kept minimal 60 degrees. Otherwise, if it's less than that, you'll not be able to efficiently utilize that particular instrument in that particular port position. Because if this angle is less, naturally, if you want to lift something up, so that you'll not have enough space for your instrument to go up because it's going to hit against the abdominal wall, right? So whenever you are planning your surgery, you have to plan your ports. This is very important. Laparoscopy does not mean just go and just start doing the procedure. You have to plan for each, especially for the advanced surgeries, you have to plan your ports. Sometimes if you are in an awkward position, you need an extra port to be placed. Naturally, all these principles would help you in deciding where you're going to place your ports. So at all times, keep all these principles in your mind. So So what do you understand by this baseball diamond concept and triangulation? People who have attended this workshop previously, I'm sure, would be able to give a feedback on it. What do you mean by that? Nobody knows. Oh, I'm disappointed.
By this, actually, baseball diamond concept meaning is a surgeon and the camera port and the target organ. They should be in the same line.
Okay, all right. So is it something? So let me simplify it for you. What do you mean by triangulation? Each of the instrument that is going in should form a triangle with the camera, with the other instruments, with no matter how many ports you have put in, all the instruments should form a triangle with one another, and the apex of that triangle should be at the target anatomy where you're operating. Okay? So if you do that and then you draw the line, what is this? This is diamond shaped? So this is the concept. So just to simplify it, just remember each one of the instruments should form a triangle and the apex of the triangle should be at the site where you're operating. Okay? So what are ergonomics? So this talk of mine was supposed to be on ergonomics. What do you understand by the term ergonomics? All of you have been doing laparoscopy. There are lots of people sitting here who are consultants, who are faculty, who are doing quite complex procedures as well. What do you understand by the term ergonomic? Interaction between man and machine. Okay. Port placement. Okay, so there's one answer, port placement. So what do you exactly mean by interaction between man and machine?
The operating table should be at a particular height. The instrument should be comfortable at the arm's length, and angulation should not be.
Okay, so all the things related to the laparoscopy would constitute. What does the word ergonomic exactly mean? Work environment. Ergos means work and nomos means the organization. So the science of studying any work, how is it being done? So it would involve anatomy, physiology, psychology, and engineering, like you said, interaction between man and machine. So that is very correct. So ergonomics do not just mean the port positioning. It means your theater layout. It means where your monitor is. It means where you are standing as a surgeon. It means where you have placed your ports. How far are the ports from the target anatomy? What are the instruments that you are using? What is your position in relation to the patient's position or the table's position? So all these things constitute your ergonomics. And without you understanding the ergonomics, you cannot do the procedure efficiently. All right? So what should be the theater layout for doing laparoscopic surgery? What is the ideal theater layout for doing laparoscopic surgery? Anyone? Come on. मैं final year की workshop कराती हूँ, they come up with the answers like this, believe me. What is the ideal theater layout for doing laparoscopic surgery? You're all laparoscopic surgeons sitting here. You just told me somebody has done, I think, even quite advanced procedures as well. Come on. Ceiling mounted tower. What should be the theater layout? What is the correct answer, guys? It depends on what surgery you are doing, isn't it? Right or wrong? So where should the monitor be? Where should I be standing as a surgeon?
Coaxial alignment. There should be coaxial alignment. The monitor should be in front of the target organ. Surgeon and the target and the monitor should be in the same line.
Very good. So remember, the easiest answer is which surgery you are doing. Where is your target organ? The monitor is always placed on the side where you are operating. Surgeon almost always stands opposite to the side where you are operating. Okay? Camera person has always to be on side of the patient because he can, of the surgeon, not in front of the surgeon, because then the view would be clashing, okay? What should be the patient's position? It depends on, again, the type of surgery that you're doing or the side you're operating. That side should go up because you want rest of the viscerals to fall away. So theater layout is absolutely must for you to know before you plan the laparoscopic surgery. Okay, so whenever you have a surgery on the list, you tell your resident, this is the theater layout that I want. You do not want the camera, the monitor to be on the same side where you would be standing when you're going in for the laparoscopic surgery, okay? So now coming on to the port placement, very important. If your ports are not properly planned and placed, you'll struggle throughout your surgery, okay? So there are different methods to place the ports. So one is the contralateral port placement. What does that mean? That means you have ports on both the sides. That means right and left side, okay? So what are the advantages? So it provides ideal triangulation and visualization for knot tying, okay? But it has got poor ergonomics. Why has it got poor ergonomics? Because if I have ports on both the sides, I'm going to work like this. So how do I improve the ergonomics? I would improve the ergonomics by just tilting the table towards my side where I'm standing. That's going to improve the ergonomics. All right? So it is going to provide you good triangulation, and it has poor ergonomics, but if you tilt the table towards your side, then that's going to improve your whole procedure. Okay, so ipsilateral port placement. So that means your ports are placed on one side. It can be your right side, left side, depending upon what you are going to do. All right, so good ergonomics, but you do not get good triangulation. But sometimes you need to do that because when you're doing, for example, abdominal wall hernias or something like that, so you need your ports on the same side, or you're mobilizing the colon, you need to stand on one side and do it. So there are different methods to do it, but you should learn the port placement, and don't forget the basic principles of triangulation. So if there's a midline structure, then this is how you're going to place your ports. Theater layout we have already talked about. Monitor on the same side where you're operating, surgeon on the opposite, camera person next to the surgeon. Assistant can again be on the side depending upon what you want your assistant to do. All right. So this is how it should be. So do you think this is an ideal theater layout? Why? What's not correct here? Apart from the quality of the picture. What else? What is wrong with the monitors? I cannot make out. So he has got a monitor there. He can always just, look here. Okay, so see, this person would be able to do the surgery. But I think that would be his last surgery that he would do as a surgeon, because he's going to have multiple problems at the end of the surgery. And the same would apply to this person here, right? So ergonomics would involve all the time, all these things. So straight line principle, triangulation, manipulation, elevation, low lying table, gaze down view. So what is the ideal position for you to do laparoscopy? Because you see, efficiency of surgery, it's good. Means you have done a good surgery, that's good. But you have to think about yourself at the end of the day as well, because that's not just going to be a single surgery for you. If you're looking at to make it a career for you, you have to look after your own health as well. So why is robotics nowadays so popular? Is because of this aspect mainly. Because they found that the surgeon-related injuries or hazards are less with robotics as compared to the laparoscopic surgery. So ideal position, remember, visual angle to the monitor, 15 to 40 degrees below the line. We usually keep our monitors here. That is the reason we develop what? Surgeon's neck, osteophytes in your cervical vertebra. And remember, your arms should be anywhere between 70 to 120. Ideal would be this, okay? And instruments should be like that. You should be standing straight. And your foot pedal should be at the same level near your foot so you're not struggling. So this was about ergonomics. Let's now come on to the first thing. So this would not take much time. So needles. So most of you said that you were interested in learning intracorporeal suturing and knotting. Before that, I think you need to familiarize yourself with the needle. Okay, so and the different parts of the needle. So this is your needle. Okay, this I'm sure you all know. This is the tip, this is the body. This is the radius of the needle. This is swatch, cord length you need to know, and needle diameter. So for the purpose of this workshop, we're going to divide this needle into 3 parts, okay? There's a proximal 1/3, half, and the distal 1/3, okay? So PX would be the point between the middle third and last 1/3 of the needle. PX. PM is going to be the middle, right? And PB, first third and middle third of it. This is your PB. All right? PB, PM, PX. Got it? So this is the swatch. So how do you introduce the needle inside? So there are different methods to do it. So there's a direct trocar entry. So if you're using a 5 millimeter port, your straight needle is going to go in directly. Okay? For 26 to 36 mm needle, which is the usual size of needle that you would use when you're doing suturing, you would require a 10 millimeter or 12 millimeter port for direct entry, right? So there's another method, backloading. So what do? Grasp the suture 2 to 3 inches from the swatch of the needle. And can we play this, please? No, back, please. Yes. So this is the backloading. Hold it from point A, which is 2 to 3 inches from the swatch. Go in. And that's how your needle is going to go in. Got it? So this is a 5 millimeter. That was a 10 millimeter port, so it went in easily. With this, it's not going because of the size discrepancy. Another method to do it. Take your port out, go in. There you go. All right? So if you have a straight needle, you can directly pass it through the abdominal wall as well. So now needle handling. How do you handle the needle? So there are different methods to tackle that, okay? So once your needle has gone in, you have to utilize some maneuver to hold the needle. So there are different methods to do it. So it's good for you to learn each method, but at the end you can decide whatever works for you. Sometimes 2 or 3 different methods would help you, and sometimes you can just stick on to one method. So there is a method which is known as wake up the needle method or hair pulling maneuver. So what do you do in that? You use point of PX to perform these 2 maneuvers. What was PX, guys? 1/3. This is your PX. PM, middle, you can use it for coffee grinding maneuver. So I'll tell you what these are. These are just fancy names, but the technique, when I'm going to show you videos, you'll be you can familiarize yourself with it, and you would know that yes, this is something that you have seen being done by surgeons. Then there's a flag maneuver, and then you can go for the fine adjustment of the needle. So how do you wake up the needle or hair pulling maneuver? So you use your needle holder to hold the needle from what was that? PX, okay? So how do you do hair pulling maneuver? Is that the thread with your left hand is pulled tight with the assistant forceps, exerting traction in a vertical direction towards the abdominal wall, okay? So you grasp it, this needle tip might be pointing anywhere. In order for it to point in the right direction, what you need to do is just pull on this thread. Don't hold this too firmly, otherwise whatever maneuver you're doing with your left hand would not be transmitted to your right hand. All right? So once you have done that, the needle is in an awake state. What do you mean by the awake state is that the proximal end is angled at 110 degrees with respect to the needle holder p-axis. What do you mean? Look at this. This is the p-axis of your needle holder. This is your needle, and the angle between the two is 110. So that means it's not at the 90 degrees. It's not facing at exactly on the left side, but it's slightly at an angle. Can we play this, please? Excuse me. Hello, play this. So this is coffee grinding. For coffee grinding, this is what? What are they doing? Yes. So all these maneuvers, you'll be now, after this small talk, you'll be required to do it on the simulators. So this is coffee grinding. Hold it from the middle, hold the thread, and try to rotate the needle in your instrument all the way around, okay? And you have to do it with your right hand and left hand. Remember, you have to be bidextrous. Flag maneuver is very easy. For flag maneuver, you have to hold the needle at PB, okay? So, or make it simple from the proximal end, proximal 1/3, and then you pull the thread up towards the abdominal wall. So that's your flag maneuver. Can we play the video, please? So there are different methods to do it. Now you'll see combination of all the methods here. So what is this? So coffee grind, it's also known as the dancing needle, so that the thing is the same, okay? Which maneuver are they going to do now? Yes, that was hair pulling, very good. So now with the right hand? Yeah. So this you have to do on your simulators and show it to us, okay? So the idea is to you should know how to get the needle in an optimal position to pass it through the tissue. Sometimes it is straight, sometimes when you are suturing, you have to get it angulated. So that is the reason you should know how to, next please, how to fine tune your needle within the needle holder. See, so it's combination of all the methods. So whatever works for you. Initially, you stick on to the one standard technique, and then you can always fine tune it according to what works best for you. See, this is what? Hair pull. So how would you know that the needle is now in an optimal position for you to take the stitch? Anyone? Come on. This was supposed to be answered. How would you know that? Okay, sometimes you want to take a back suture. So what would you do? You would do a coffee grind or a dancing needle and get the needle in an opposite direction to take a backhand stroke, right? Okay. So that's it. So this is a very interesting one, most important one. Keep on practicing. Even if you have to eat with your laparoscopic instruments, do that. That's going to make you a very good laparoscopic surgeon. Okay, so now you know, I think they have names put on each one of those stations for you to go and work. You'll be given 15 minutes, if I'm right. Yes? 15? Yeah, on each. Okay, so 30 minutes for this exercise. Come on.
Sure, all our participants are enjoying and learning.